Hi, and thanks for joining today's webinar. My name is Mike Herlin. I'm a member of the Collaborative for Telehealth and Aging. In this session, we'll start with a presentation on delivering telehealth services to older adults in the post-acute and long-term care facilities, followed by a panel discussion. We're joined by Dr. Dallas Nelson and Dr. Suzanne Gillespie from the University of Rochester School of Medicine. And the panel discussion will be moderated by Katie Darling from Dartmouth. Please use the Q&A feature to submit your questions for the presenters. And I'm going to hand it over to Katie and team right now.
Thank you so much, Mike, for that lovely introduction.
It was quick. Folks just want us to get right into it.
So we're going to be talking about telemedicine in the nursing home. This conversation is actually one of a few very exciting conversations that we can have because we're talking about a tool, telemedicine and telehealth technologies, that has a pretty well-established win-win track record. The application of telehealth in long-term care, post-acute settings actually is one that has demonstrated benefits for both providers, for healthcare facilities and systems, as well as benefits for older adults and caregivers. And that's part of the reason that it's such an exciting conversation. When we look at telehealth from the perspective of providers and health systems, there have been evaluations that have demonstrated that there's a high level of provider satisfaction with the use of this tool in practice, that it can help to improve the delivery of patient-centered care. So when you think about that biopsychosocial model of care, that using this tool can really help you to meet the patient where they are and understand the factors that are influencing their health care and ability to engage in healthcare systems and treatment. We've seen that it's demonstrated cost reduction through increased efficiency, that it's helped to increase clinical efficiency because you're able to decrease the amount of cancellation rates that you might see in clinical setting. And ultimately, it creates better performance measures. From the perspective of your patient, your older adults, we've seen patients tell us that it's improved their quality of life, that it's created better access to them to high quality care. That's both for urgent care and also for subspecialty types of care that might otherwise be difficult to access, particularly from underserved settings. We've seen that it's created a decreased burden for care through things like decreasing travel necessities. And there have been several studies that have demonstrated the impact of telemedicine on decreasing avoidable emergency department transfers, and then as a relationship, also decreasing hospital admissions. So really a win-win tool. There was a review of telemedicine in a nursing home that was published in JAMDA in 2021 that looked at the use of telemedicine and telehealth. And I think this statement from that article says it all. To date, in no study has there been unequivocal evidence that telemedicine or telehealth negatively affected resident outcomes or presented an excessive cost burden. This is a tool that's accessible and can promote good care. We saw that during the pandemic, the tool had some good incentive for people to pick it up and use it in care. This is a graphical representation of that was published in JAMA Network. You can see in the A figure that during 2020 into 2021, the height of the pandemic, we saw a real rise in the use or in the delivery of telemedicine visits for both long and short-term residents in nursing facilities. This increase, however, decreased as the pandemic impacts on healthcare delivery were lessened. We saw that decrease in skilled nursing facilities return the use of telemedicine significantly, much more so than what we've seen in other outpatient settings. That's what's graphically represented in B. So we know that this tool, for whatever reason, in nursing facilities, hasn't maintained the uptick that its use during the pandemic allowed us to achieve. And part of that reason is probably because of how we've designed our systems to use telehealth and telemedicine in the delivery of care in post-acute and long-term care settings. We know as experts in this setting who use telemedicine that age-inclusive design of telehealth is really key to realizing the benefits of this tool in delivering care for older adults.
I'm going to do a little review with you on what the collaborative came up with were the age-inclusive principles of telehealth, and kind of give you just what are those principles and give you an example of those principles in practice. And nobody's here to say that implementation of telehealth is easy in the long-term care continuum, right? We have here to say that we've tried a lot and it's gone back down to almost zero. So we really have a lot of opportunities to implement. And we also have a lot of opportunities to implement well with a systemic approach. So this is what we're trying to do, is look at what sort of principles we need to apply when designing our systems. So the first principle I'll go over is equitable and accessible care. So there are multiple components of this. Whatever we use should account for the cognitive, the physical, the cultural, and linguistic differences of the patients that we're caring for. We need to ensure that they are ready for the use of telemedicine. They know what to expect, and they find it to be a good experience where they get the care they need. And it should work across all settings of care, not just in certain areas. And we need to look at the differences in technology and accessibility and connectivity in different regions and in different locations, and ensure that the providers engage in ongoing education on the best practices in telehealth. So one of the things we talk about, so in the long-term care continuum, many people in these settings are there because they have a degree of either cognitive or physical dependence for care. And so they might need, just as they need assistance with activities of daily living, they probably will need assistance with the utilization of telemedicine. And it will depend on that particular person, their degree of cognitive independence, and the complexity of the exam. You know, they may need just a picture taken if it's a dermatologic finding, or if there is a neurologic exam, you may need a person there to help the neurologist understand what the muscle tone is, to look at the range of motion, all of those things. So the type of exam needed, the degree of independence of the person determine the need for assistance in completing a telemedicine visit. But also in the long-term care continuum, it's very important to think about the need to coordinate the care in a timely way. One of the new things that has been occurring in my setting, in the skilled nursing facility, some patients or patients with families have been engaging in specialist consults via telemedicine using their patient portal without coordinating with the nursing home. So I happened to run across it. I had a conversation with the family, and a chart in the same EMR as the specialist, and I found out that essentially from the nursing home's point of view, this person had had a stealth cardiology appointment, and they had suggested medication changes, but the medication changes didn't make any sense because the nursing home hadn't had the opportunity to send the proper medication list. So the nurse practitioner who saw them didn't use the proper medication list and gave a recommendation that couldn't be implemented. And then I needed to message back and then talk with the family about the necessity of coordinating care. Coordinating care, especially when the facility is required to implement all of the care recommendations, is incredibly important too. The next principle is the need for person-centered care. So it needs to support the older adults' healthcare goals, their preferences, what matters to them. Many of you may know the 4 M's. So what matters is basic to it. Promote high value cases. So we don't just want more care. We want the right care at the right time, doing the right work. It needs to be coordinated and provide continuity of care. So we're essentially speaking against what we would call the doc in the box, some uncoordinated care that just happens without the rest of the team knowing. We need to set reasonable expectations for how fast and how frequent this can happen and how it will be done. Promote opportunities to use telehealth across the entire continuum of care, thus potentially decreasing avoidable costs, and it may be able to reduce time to access providers, and it also may make providers accessible by eliminating the need to transport the person. But also it needs to incorporate the people who are caring for that person when appropriate. So one of the things, do older adults like telehealth? So this was a study done in 2017, so before the pandemic, before a lot of people had experience with telemedicine, and there was an ongoing myth that older adults don't like telemedicine. So this is a study from neurology, and it was the connection of movement disorder patients with their movement disorder physician. So you can see that the patients were primarily very satisfied with the care that they received via telemedicine. Most of the rest of them were satisfied. The physicians a little less, but still they were primarily very satisfied with their ability to render care via telemedicine. So this isn't against their wishes, and it's maybe with their preferences to use technology to connect with their providers. The next principle is to be integrated and coordinated. And I touched on that earlier too. We need to ensure that the older adults' health records are available. Most of the people we care for have multiple comorbidities, multiple medications, and it's not safe to render care without knowing the medical history. It needs to facilitate safe and coordinated transitions of care and connect all the stakeholders. It also needs to be integrated into the continuum of care and provider practices. So one of the problems right now is how to schedule, how to connect a specialist who is accustomed to a certain workflow within their office with the nursing home patient, and how to honor everybody's time and expertise in that interaction and support staff working efficiently. So telemedicine can be very difficult if not carefully coordinated because of the amount of time that it could take staff away. It may be, in a nursing home setting, if you have to send a staff member to the appointment, maybe there's a savings of time, but still we need to work to make the system as efficient as possible. So this is we came up with a toolkit to help people implement telemedicine in the nursing home and long-term care setting. And this is one of the workflows. I pulled out the provider workflow, and I wanted to show and highlight the access and coordination. So at the beginning, the provider needs to have access. How is access done? It could be through a questionnaire, it could be through faxes and old style, but maybe they're given a login to the EMR, or some records are sent and linked for that provider to review before their appointment. And then they review that, then they connect, of course, they connect into the nursing home with the RNs and other people who can provide history, and they start the telemedicine encounter after consent is obtained. After they finish the encounter, though, that provider then has a responsibility to connect back, to get those recommendations back to the nursing home or the other facility that they may be able to follow through on those care recommendations.
So let's see how some of those 17 principles that Dallas walked us through, our 17 guidelines that Dallas walked us through, might embody themselves in a day-to-day nursing facility practice. So here's a vignette courtesy of some of our collaborative members. Let's imagine we have an 85-year-old person who's in our subacute rehabilitation facility following hospitalization for a ground level fall that was complicated by a hip fracture. On the first day, I meet with that older adult, I establish a pain care management plan with them, and the team initiates the treatment plan for that individual. On day 4, the nursing staff calls me to report that the patient has significant pain during physical therapy. I'm in the middle of a busy outpatient clinical practice day, and my facility, my clinical operation is several minutes down the road and not really close to be able to pop in. The next time that I'm going to be able to get to that facility is probably about 4 days out. And so I decide to utilize a telehealth-enabled telemedicine visit to evaluate that patient in real time that day. So I'll ask you, which of the following best reflects an age-inclusive telemedicine plan? Should I, A, establish an appointment time with the patient and nursing staff to conduct a video-enabled telemedicine visit? Should I, B, ask the nursing staff to have the patient log on to the telemedicine system and wait for me to have a moment between my clinic patients so that I can connect with them and understand the concerns about pain? Should I ask that the nursing staff contact me on my smartphone, give me a FaceTime call so that I can communicate as soon as possible and see them face to face? Should I inform the nursing staff that I really can only get to that visit if the patient is able to log on to my clinical portal? This happens a lot around here. If you're on my clinical portal, I'll do it. Go ahead. Or finally, should I just admit to myself that I'm nuts? There's no way that an older patient is going to want to do a telemedicine visit, so I shouldn't even offer it. I don't know, Mike might want to answer, but I'm going to let him pause and we'll go down to the next slide. I'll give you the answers. So which one illustrates those principles and guidelines? Well, it's A, establish an appointment time with the patient and their supporting nursing staff to conduct a video-enabled telemedicine visit.
I totally was going to say that.
I knew you were. I knew you were. You're a smart guy.
Thank you.
He's learned a lot from being in the collaborative and the resources that we've generated. So why is that the right answer? Well, it illustrates the principles. So let's click through the others. Go ahead and click onto the next one. Well, what's wrong with having them log on and wait? Well, that's not patient-centered. It doesn't respect their time. It doesn't coordinate it within their rehab activities or their care domains. Doesn't give them a chance to engage their caregiver who may want to be present for that visit. Why shouldn't I just FaceTime it? Well, FaceTime's great, right? I use it with my teenagers all the time. It's great to be able to see where they are and what they're doing, kind of get a sense for what they're telling you about the truth of their day-to-day. But is it appropriate for the clinical situation? Well, not in modern applications because it's not integrated into the healthcare system. It's not coordinated through the interdisciplinary team, and it doesn't promote integration into the medical record. So it's not ideal. What about informing them that they can only use it if they're logged on? And I've had patients told this by their providers in our practice in our region. Well, that's not really equitable and accessible if they're only able to access it if they can log on through a clinical portal. So creating those systems which leverage others to help log on and make sure that there's equitable access to those sort of clinical systems is really important. And how about finally, older adults don't like telehealth? That is not patient-centered. And while I will tell you that there are some older adults who really don't vibe with telemedicine, it's not a tool that they feel like is great for their practice. The vast majority that I've worked with are open to it, depending upon the clinical situation and the supports provided to them. And that's not exactly different from other age groups. When you look at the data that's been produced through the applications of telehealth and telemedicine in recent years, older adults are actually one of the most rapidly growing populations to use these types of tools in their clinical care. You know, I think one of the things that's most helpful, I'd encourage you to pop on over either now while we're talking or during your other free time to the website that the collaborative has developed. It's ce4ta.org. If you go over to that website, you'll find that there's a resources landing page, and it includes numerous great resources that are really going to help us as clinical providers, as caregivers, and as influencers for our health systems to think about how we can make those principles and the guidelines associated with them take life in our day-to-day practice. And this guide that you're seeing here is a guide that helps to implement age-inclusive telehealth principles in post-acute and long-term care settings. You can see from the table of contents that it's going to walk you through some of the greatest questions and processes that come up in nursing facilities. And so it'll talk about how you can create communication plans and robustly plan with your staff, residents, and their caregivers or family members. It talks through the important pieces of creating an education and training plan for all members of your team, how to integrate documentation in a reliable way, and integrate it into your workflow, particularly things around your admission workflow, your provider workflow, change in condition workflow. As I mentioned earlier, that's a great application of this tool. How to use it for chronic disease management. What are the constraints that you might consider for licensing and credentialing? So really good living tools that you can access in this guide. Finally, one of the most important parts of this guide is not only thinking about how you set it up and establish it, but how you create a performance monitoring plan so that you can understand where, once established, there may be opportunities for you to tweak the process so that it's even better for the experiences of your team, for the experiences of your residents, and finally, how you can use it to help create better clinical outcomes. And so this will talk through how you might benchmark some of your outcomes from the use of this tool in practice. One of the other pieces that I like about this tool is it talks about how to think about creating partnerships with other providers in your community that might want to provide care and resources to your residents. So chock full of helpful information. As you might have seen pop up in the chat, we've had over 1,000 downloads of this tool already. And so I'd encourage you to take a look at it and to share it with others in your thought community, in your healthcare systems, and those that you'd like to partner with to think about how you can use this tool in your own day-to-day practice and lives. I'm going to pause there. We're about 20 minutes into our conversation. And I think, Mike, I'm going to enter into some conversation and questions.
Yes, thank you very much, Suzanne and Dallas, for that excellent presentation. I think now we're going to go into our Q&A, so please feel free to add any questions that you have into the Q&A. One of the questions that came through was a question about the technologies and innovations that could enhance telemedicine services in long-term care, and how can facilities prepare to integrate these advancements and technologies?
So I think that one of the most important ways is to start conversing with your local health systems about how they would like to engage and try to reconcile your way of engaging. It requires I'm hoping that every doctor that serves a nursing home doesn't have another device, and that's because the staff would have to learn that device, and it just ultimately create a complexity barrier. So I would start with a conversation with the local health systems on, we want to connect with you. Also look at your provider group. Maybe your provider group is not in-house all the time. What are the opportunities for your provider group to connect, and what modalities would you like to use? You would want to use a HIPAA compliant platform. You would want to know what kind of equipment there is. I actually have to usually spend a good deal of energy educating the secretaries on how to educate the other specialists on what our opportunities to connect are. Our Zoom address here is, and all you got to do is type that in, and then we'll connect, promise. I think you got to look at all of your communication formats so that people can engage. And you really don't need necessarily a complex, lots of a full cart to do a lot of visits. You can do a lot of visits without everything needed, and just get started with something pretty simple.
Yeah, Dallas, you're exactly right. I think the advancement of technology that's probably the greatest is sort of the reliability of that interface and the user's familiarity with it more than any one specific technology. I think one of the advancements that we're seeing more and more, and hopefully will continue to improve, is some of the ability to utilize the electronic health record and integrate that across settings of care in some of the integrated electronic health record access, which really is able to promote much better care for individuals who may otherwise have limitations in their means to physically integrate a non-electronic record.
Another question that came up in the chat is, what is the reimbursement climate for telehealth services into SNFs and long-term care facilities?
So there's a little bit of up in the air there, because there's many of the waivered telehealth capabilities will expire December 31st, 2024. What I've been told by, experts is that, the Congress likes telemedicine. They've had telemedicine. And even if it's a lame duck Congress, this may be something that once, now that the campaign's over, they're willing to extend some of those capabilities. But it is a moment of uncertainty for many of the capabilities in the nursing home.
Yeah, I think just piggybacking on what Dallas said, historically, if you look pre-pandemic, there were some limitations on, rurality and other factors that really constrained some of the use of telemedicine in nursing facilities. I think we can expect those to permanently go away, and the climate to really open us up for particularly change of condition, specialty consultant visits in long-term care. I think related to sort of whether this tool can be used for regulatory visits, I would suspect that there will continue to be some constraints in that domain, which, to sort of promote that ongoing in-person in facility care. Again, it's a tool, and so it's not meant to be the only type of care that's rendered in a facility.
So I would
for the
put
other
out
I think
the one big win was the frequency of visits.
Mhm.
Regulation is not going to come back in the long-term care.
right, the use for regulatory visits, and we've heard that in conversations.
No,
in terms
the
of-
14 to 30 day gap in that we lobbied over, they said that that's permanently removed. So
Right, so what Dallas is talking about, there was at one point a constraint on how frequently telemedicine could be used or billed for in the nursing facility, and we expect that to go away. But the type of visit, for regulatory visits, that survey manual regulatory visit requirement, those are not likely to be one that's able to be used by telemedicine. The other piece related to the financial climate for nursing facilities is, remember that facilities still can use originating site charges as well, which is another opportunity for some financial incentives for facilities. It's small. I think it's around $30 a visit or something right now for facilities that originate telemedicine visits for residents there, but it is something that can be tapped into by facilities, and so it's another piece of the financial business model.
Another question that came through the chat was, how do you incorporate emergency department into the process? So the processes that were discussed, how does that affect, the care for the emergency department setting?
So the most of the use cases when it comes to changing condition in a nursing home or assisted living. So Suzanne and I did research in senior living facilities, and it was for acute change in condition. And we were able to have a significant reduction. I think it was 16% for all comers and 22% for those with dementia in the senior living facilities, with the utilization of telemedicine to evaluate change in condition. Nursing homes around, I'm off the top of my head, but about 16% reduction in transfers. To admissions, I actually think to admissions to the hospital, I think that was that data. So most of the data I'm aware of is an effort using telemedicine to avoid transfers to higher levels of care, but to render that care where the person is. So I have not seen, unless somebody can correct me, data of emergency department into a nursing home. but instead the primary team or another team rendering the care within the nursing home.
Thank you. Another question that came through was there's still some hesitation amongst providers to really incorporate telehealth into their standard operations. What would you say to kind of help them move towards, incorporating telehealth practices?
So I'll take a crack at that one. So I think, change is hard. As they say in the quality improvement world, the only one that likes change is a wet baby. And use of this tool is certainly can be a disruptive change for those that are used to one sort of practice style. And so in my own experience, I would continue to ask. I think that's one of the things that we've learned, that folks won't necessarily think of it first or offer it first if it's not yet a routine part of their daily practice. And so we've tried to establish a pattern of where we ask and facilitate, surround that provider with supports to try and make it effective. And I think that that's helped our medical providers and our partner consultants to gain some confidence in the efficiency and use of this tool. And so I would say continue to ask and provide support to make it as efficient as possible. The other thing that I would say is, continue to look for your champions because as you're able to establish it as a routine and reliable part of practice for providers who, for whatever reason, have made it a part of their practice, who are more facile with technology, the more we're able to create systems and leverage those super users, if you will, the easier it is for the rest of the community to see that practice and sort of follow the cue and join in. I think from a tool perspective, this isn't going to be every provider, every encounter, every resident, but the places where we can forge that relationship effectively, it will help others around us to be better. And so I think those are the two things that have worked in our practice here.
I'm trying to engage, I work for the University of Rochester, and I'm trying to engage the University of Rochester in building some sort of telepresenter system to allow for post-hospitalization specialty follow-up using telemedicine. I started with neurology because many skilled nursing visits are for the strokes or something like that, where they're following up with a neurologist. The neurologist noted that they had a significant no-show rate from these nursing homes, in part because we have a transportation problem. And the transportation problem is only worsens our ability to discharge to the nursing homes, right? Because the same people that are taking our nursing home patients to their specialty appointments are the same people that will take people out of the hospital. So the hospital has a vested interest in looking at trying to systematize some of these visits. So we've also had peri-op and some of the most complex patients they're thinking about doing surgery. We had fellows do the telepresentation, I think, for the perioperative evaluation. I'm not going to say I've been successful in getting that. There's a lot of steps to go forward to building a system. And I think that that's why the nursing homes hasn't taken off like other settings, because of the necessity to build a system for it. But I do believe there are incentives that are aligned for doing it. And I think systems, healthcare systems have reasons to do these visits to render better care, and financial reasons.
Mm-hmm. Yeah, thank you. So I think now we're going to transition into the panel discussion where we'll dive a little bit deeper on some of these topics. If people still have questions, put them in the chat or put them in the Q&A because we can still read them out. So one thing we'll talk a little bit more about is coordination. So Suzanne, what are some strategies that can improve communication and coordination of telehealth visits with external providers and specialists?
So sort of jumping on what Dallas said, our ability to improve communication and coordination with our subspecialists, first starts with establishing that bidirectional chain of communication. And frankly, that doesn't have to, that's not necessarily a medical provider or sort of a licensed individual that needs to have that communication. We really leverage those communications at the level of our administrative support team in connecting with the clinical operation in advance of an appointment, in electronically sending over records that the provider may need or want to have at that appointment for effective review, and creating that contact point for issues that may arise during that visit. I'll tell you, I think any of us in post-acute and long-term care practice can tell you the sagas of people showing up at a clinical appointment and the provider having no reason what they're there. For whatever reason, the packet of information from the nursing facility is missing and no one seems to know. And you, on both ends of the interaction, don't really feel like you've added any value because you come back with unanswered questions. And from a patient-centered perspective, you have that burden. The ability to create that communication, even at an administrative level, to say, hey, here's the packet, here's clearly the question, here's the number if the folks looking for some questions, really promotes great conversation in real time. And so that's a strategy that we use in confirming the appointments consistently, taking away some of the time resource that we might have put into arranging a transport vehicle, taking the person to the lobby to wait for the Medicab or whatever, looking for them to return, and reallocating it to really as a concierge, if you will, for that person's telehealth appointment. And it's been really very effective.
Yeah, we have the most common utilization is our psychiatric services here, and they have definitely come up with a system. And so everybody knows what to expect with the visits. They know exactly when they're going to have, they know the information that they're going to need to present at those visits, and then how they're going to get the visits back. So it does speak to being able to invest in the system and systematizing the interaction and how successful it can be.
Yeah, I think that's a great example of where just as simple as setting up sort of a standard operating procedure for a specialty clinic and repeating it over and over again has enhanced communication and expectations. A really good example.
All right, so in thinking about some dementia care, what should providers consider when using telehealth to care for older adults with dementia? Dallas, do you have any suggestions?
Well, I would, so one of the things I've been thinking about is in dementia care, so primarily the patient can't really negotiate their plan of care, so we do need their care team, their caregivers, as part of those interactions. That being said, the caregivers, I don't know if any of you have taken care of loved ones with dementia. It's a big deal, and it's very hard to get children to have to miss work for appointments and all of that. So we've worked recently with the university we're going to try to reverse engineer our dementia unit rounds. So we're trying to, number one, make sure that all of the families and loved ones know exactly when our appointments are. We're going to ask them through the portal to tell us of any concerns ahead of time, so that we're able to gather information and be prepared for the visits in the best way. Then we're going to, a little bit like the cable person, tell them we'll see them between a certain number of hours, and ping them when we're ready to do the visits, because we recognize, after hearing actually part of this collaborative, the idea that people are just supposed to wait around for doctors. And it's not very patient-centered. So we want to say, okay, we're ready now. Let's have our interaction. And we want to bring the family we're going to see the person, the patient in person, but we're going to bring the family in as remote for the visits, so that they don't have to take off work and all of those things, thus negotiate the plan. We also are going to set up the expectation that the final plan will be in the notes. The idea is that, if any of you have done complex chronic care management, once in a while you have to double check 3 specialist notes and all of those things to come up with your final idea. So we are going to say, the final plan will be in the note. Please review it and let us know. So this is really trying to incorporate the care team into the care using technology. So but it's not necessarily telemedicine for the patient. I am working with the university to figure out, making sure that they don't bill it wrong. They do the place of service billing and they don't use the telemedicine place of service and all of those things. There's lots of logistics to think through when doing it, but the records, the electronic records are getting good enough to do this kind of well now, and you can incorporate it. And I was about to go off on my own and do something rogue, with the university, but I did ask my informatics folks, and they're like, no, we have a better way, Dallas. And so I was able to work a better system that won't require as many legit training and will be better coordinated within the entire EMR. So I'm very excited to start this. It's new for me, but and I can report some other day on if it was successful.
Katie, I think I'm going to take that question a different tactic to Dallas's, because when I think about things to promote the use of telehealth and telemedicine for individuals with dementia, I'm pretty passionate about it because I think it's a myth buster. As Dallas mentioned, we've done a little bit of research in using telemedicine to care for individuals in senior living communities. And one of the biggest aha moments for that, for me, in that research project was that it was actually the individuals with dementia that got the greatest benefit from our use of telemedicine for acute change of condition. They were most likely to benefit from having avoidable emergency department utilization, hospitalization use. And I think, it wasn't necessarily something that I expected, but it stands to reason, right? Those individuals may have difficulty accessing care as readily as individuals without cognitive and functional impairment. And I think that's true in our nursing facility practice as well. They're most likely to need additional supports. They're most likely to have challenges when created with unfamiliar environments for care. And so I totally agree with Dallas's rogue initiatives to try and engage caregivers and so forth. I'm not sure it's exactly rogue, but because I think that is one of the great uses for telemedicine. I think more granularly, when we're using telemedicine in the nursing home, we have to remember that individuals with dementia can engage in telemedicine and video-based services. They often already do. Their grandchildren are calling them. They're, joining in on a Zoom meeting for this or that with family members. I think the ways that we promote that are we offer it in an environment that's familiar for those that might otherwise have psychological symptoms associated with new environments. The same way we would for others, making sure that it's quiet and that it's centered on them so that they're able to see the computer screen, so that the audio is adjusted for their needs. I've had individuals that we've actually plugged in headphones so that they could hear straight on in a more reliable way, or that have been able to engage their hearing aids to integrate with the video systems that we're using. Making sure that the lighting is on, because watching a video screen in the dark is very different than one that is light enhanced. Those pieces, bringing their favorite aide or staff member in to support the visits, those tiny things, while small, actually significantly improve the sensory input and the interactivity. And so it makes care interactions much more acceptable to those with cognitive impairment. And so I think just taking a quiet step to think about, hey, what have I done to make this the best environment for those visits is even more important for those with cognitive impairment. There's some tools. If you head over to the website, there's some tools about accessibility for telehealth, some things that can help us to gauge digital literacy and the use of our systems that I think are especially true for those with mild to moderate cognitive impairment. Not as rogue an answer as Dallas's, but.
But one of the things I think our research showed is that the fact that some of the patients couldn't be as specific about their symptoms. We knew they felt poorly, we knew what was going on, but we were able to deliver timely studies to further enhance and triage how sick they were, allowed us to keep them in their setting that they're most familiar with. I really think that delivering some of the higher level services to round out a clinical picture really does help change decrease the uncertainty of not escalating care.
As we think about workforce challenges, how can telehealth mitigate workforce challenges in long-term care facilities? Suzanne, any thoughts on that?
Yeah, I mean, workforce challenges in nursing facilities are robust. You know, when I think about sending out frail and vulnerable older adults from my nursing facility, often they need companions. The companions sit and wait for them. They sit in the transport vehicle. They go out to an appointment where they, again, in return may wait. I had one patient a couple weeks ago that on a Friday afternoon was sitting for hours after having been forgotten in a subspecialist visit. Then they return and we embark upon trying to understand, fill in the pieces of the puzzle that the consultant didn't have, to get their notes, to follow up, to understand what to do. And so I think this is part of the plan that's sometimes difficult to measure because we're deploying a Herculean amount of workforce in supporting that resident to go out for consultant visits, for example, and to return and make sure that we're able to get recommendations that are integratable into our nursing facility plan of care and establish the monitoring that happens afterwards. So in our experience, I think we've been able to leverage workforce by deploying some of the basic data gathering and technical skills to initiate telehealth and telemedicine visits for our residents, again, using our administrative staff or others that we may have trained in as part of their position role in facilitating that visit. Then integrating it into clinical practice, we recoup quite a bit of workforce by creating that efficiency, by allowing our staff to remain in the facility in a more efficient process so that they're not accompanying residents, and decreasing that back end work, wondering what happened at the visit. Did they actually have a clear plan of what we were already doing? Do we know how the feedback happens? And so, you know, I think we think often about the workforce struggle as who's going to click the button to turn on the Zoom and how am I going to sit there for 15 minutes rather than thinking comprehensively about the plan of care. And so the two pieces that I would say again is to think about the whole measured group, and also to think about this within the context of the entire team that you have in your facility. And when I say team, I'm including family members, I'm including our non-licensed staff, as well as our licensed staff and medical staff, to think about how we can use all of our resources together to access care, both in subspecialty types of care and also other types of urgent care. But I actually think this is a big win for workforce in nursing facilities. Similarly, I think it's a win often for those on the other end, providing either consultative services or acute change of condition services as well. For many of the reasons that we listed in that early slide. It creates a better picture of the patient. There's an ability to integrate it into your other practice environment in an efficient way to eliminate those no-shows. But it still offers you that real person around the dining room table, if you will, perspective on what's happening in a person's daily life. So I think and remember, those settings don't have a lot of workforce either, to be calling the nursing facility and asking about this or that, or to be trying to support an individual with significant behavioral symptoms while they're there in their clinical practice setting. So I do think it's a win-win. It's part of the reason that originating site fees might be something that you can recreate. But for me, telemedicine is a workforce solution.
And then I'm just thinking about some of the technology aspects for long-term facilities with limited resources. What basic technology and trainings are needed to establish and sustain a telehealth program? Dallas, any other input in that area?
So the research that Suzanne and I did, we had trained telemedicine technicians in a big old cart with EKG and all of that. But then I tried later to implement telemedicine in the nursing home with a cart, and it just had like a surface and a Bluetooth stethoscope and an otoscope or a camera. And the truth is, we never use the stethoscope. And we never use the camera. We pretty much just use the Surface to do audiovisual conferencing. And you're really able to, if you've got a good set of vital signs and a good look, and you're assessing the global picture, you've got somebody telling you some history, you're able to do a lot. Maybe not everything, but a lot. And you're getting further than you would have been. But the other part about it is that you can't estimate how simple you should make this system. I made a mistake. We required that the nurses double tap in the same spot. And I had a nurse who could not tap in the same spot twice. I don't know what that was about, but I watched. So the better system had a big blue button, and then they just hit that button and you're connecting. So as simple as you can make it is the best solution there. But it really doesn't have to be all the bells and whistles to get started. You really, that may be a specialist that's or your primary care person that's very engaged, and you can get a system going, but not necessarily necessary just to start doing good care.
Yeah, I couldn't agree more. I would say the second take home message is don't let technology paralysis limit your ability to start using this tool in your practice. And so as simple as an iPad, something with a video connection that you can establish is really all you need for probably the majority of visits. To start small with those sorts of things. And then as you build your experience and relationships with certain types of specialty care where you may want more advanced technology available, build that into your repertoire. But really all you need is a couple of willing humans, some cellular internet data, and a video connection.
I think we have time for one more question. So what strategies can encourage buy-in from facility administrators to support and invest in telehealth programs for long-term facilities?
Well, they have their quality measures and admissions to the hospital, readmissions to the hospital, and transfers to CED are some of their important quality measures, which this technology has been proven to improve. But on top of that, the transportation problems and the staffing, as Suzanne was getting at, the need to send staff to appointments and the loss of that workforce within your building are all reasons to do it. I also think that there's a huge patient satisfaction win there for those. And we think in our nursing home, if they have a good experience on their skilled stay, maybe they'll come back for a long-term stay one day if they need those services, if we have a good experience for them. So I think that the families are some of the biggest insisters on not going out. They can be very tired of going out, and the huge burden that it is for the patient and the families. So I think that there's a lot of reasons that administration and the nursing home itself would want to invest in this.
Yeah, absolutely. I think, Dallas, you've given the best pearl here. It's look at your facility's overall strategic plan. If there's a quality measure that you're looking at where this tool might fit, maybe that's the springboard to leverage it. And there's quite a few of those, right? There's some psychotropic use. Maybe it's a way for you to leverage access to good mental health care provision through telemedicine tools. Maybe your wound care rate isn't what you'd like it to be. Maybe this is a place where you could use some of that video enhanced ability to promote better wound healing in your facility. Emergency department utilization rates higher than you'd like them to be. Hey, is this a way we can look at improving our change of condition management? I think a lot of those integrate so well into some of the things our facilities are already working so hard to provide for our residents, and already such an important part of our strategic quality assurance and performance improvement plan. Think about where you can make it a win-win situation, where you can both put in place a tool that has demonstrated outcomes and also improve your facility's experience with something that may have diverse applications for other concerns. That's how I would approach it if I were having a conversation with my administrator. And then as the cell, throw in some workforce, throw in maybe an originating fee. And then I think you start to have a plan that makes sense. The other piece here I would say is create the plan with some of the performance metrics that are in the tool guide that the collaborative developed, because I think it makes it a very compelling case. And so some of the language and approach that an individual might want is detailed for you in that tool.
Well, I'd like to thank both of you, Dallas and Suzanne, for this great presentation. It was very insightful, very engaging discussion. Appreciate your time today. We do want to let everyone know that this has been recorded and it will be up on demand on the CE4TA website. The next webinar will be held on November 20th. There'll be more details to come soon on that webinar. So thank you everyone for joining us. And again, Suzanne, Dallas, great engaging conversation. Thank you so much for your insight.